I'm Rachel Neiman, and this is an observational placement and project-related presentation for the School of Medical and Applied Sciences at CQ University. This presentation will include a discussion on the observational placement at a rural physiotherapy practice and a subsequent project on a clinical population. Placement content will include background, population, tasks observed and completed, contribution to the workplace, learning and skill development, and self-reflection. The placement took place at a rural physiotherapy practice in Queensland. The practice incorporated a DMA clinical Pilates rehabilitation facility, and the target population of patients were those requiring physiotherapy treatment for a musculoskeletal condition. Practice staffing included 1 full-time physiotherapist, 2 physiotherapy assistants, 2 reception staff, and a massage therapist. The population description were males and females aged 26 to 78 years with musculoskeletal conditions, mostly including knee and hip replacements, knee and shoulder reconstructions, and a high number of lower back pain patients. The lower back pain population included disc degeneration, disc herniation, nerve impingement, spondylolisthesis, post-operative including laminectomies and discectomies, and some patients had idiopathic lower back pain. Duties observed included clinical assessment by the physiotherapist of lower back pain patients prior to exercise. This involved manual treatment, including soft tissue massage, heat treatment, inferential current treatment, joint mobilization, and dry needling. The prescription and delivery of individual exercise programs was also observed, along with the constant physiotherapist-patient interaction of pain levels, exercise instruction, and general feedback. Tasks completed while on placement included setting up of the Pilates equipment to the specifications of the physiotherapist for every patient and every exercise. Thorough cleaning of the equipment between patients was also conducted. Exercises completed were checked off with special considerations noted on each patient's chart under the supervision of the physiotherapist. The booking of future exercise sessions for patients was also completed where necessary. Contribution to the workplace was done through assisting the physiotherapist by setting up and cleaning equipment, which enabled the increased efficiency of exercise delivery and the transition between patients. This helped facilitate the timely completion of exercise sessions, allowing subsequent appointments to run to time. Assisting with the administrative duties also helped the physiotherapist by freeing up time to spend with other patients or recording clinical patient notes. Learning while on placement included the use of Pilates equipment to create a challenging but safe workout for clinical populations. Changes in the setup of Pilates equipment includes increasing or decreasing spring tension to progress exercises, as well as decreasing the stability of the patient's base of support. Placement learning also included the difference in exercise prescription in clinical populations. It was observed that a very light exercise session for a healthy participant could be physically exhausting for clinical patients. Sometimes even the safe mounting and dismounting of exercise equipment also provided a considerable challenge for these patients. Learning was also obtained through the observation of the effective running of the physiotherapy practice, from treating patients to liaising with other health professionals, government departments, and private health funds. Following the correct procedure for billing and making appointments appeared to be vital for the efficient running of the practice. Skills developed on the placement included interaction with the patients, learning what questions to ask to obtain valuable feedback on the patient's condition and perceived efficacy of the exercise was a valuable skill. Learning to think laterally to accommodate different patient responses to exercises was also a valuable part of the placement. Pilates equipment is very versatile, and slight differences in setup can make a huge difference to the efficacy of the exercises of the patient. All appointments and billing were conducted through the software program called Front Desk, which is designed for health professionals. Booking future appointments for patients under the correct categories for the different services offered by the practice was a valuable skill learnt on placement. Self-reflection on the value of experience and future career pathways. The placement experience of observed exercise in clinical Pilates facility was very valuable. Exposure to the intricacies and potential of Pilates as a form of exercise for everyone from elite athletes to clinical populations has resulted in wanting to learn more about and incorporate Pilates into my future career pathway. Learning of the large amount of time involved in the administrative side of an allied health practice has at this point in time discouraged me from following this pathway. I have now decided to postpone postgraduate study and spend more time on professional development through Pilates training. Long-term pathways, however, may still include postgraduate study either in exercise physiology or in the field of research. The remainder of the presentation will cover the project, Clinical Pilates for Lower Back Pain. Back pain, back problems and disc disorders are the second most common long-term health condition in Australia, with up to 13% of the population suffering from lower back pain at some point in time. Inactivity in lower back pain sufferers can lead to overweight and obesity, which can lead to further spinal degeneration. Structural changes, including decreased bone mineral density attributable to low levels of physical activity, also can contribute to lower back pain. This includes decreased intervertebral disc height, increased fat content of the multifidus muscle, and high levels of pain. It is well known that physical activity, particularly weight-bearing exercise, is crucial for maintaining or improving bone mineral density. Decreased strength and core musculature is also prevalent in lower back pain sufferers. The addition of core stability exercise to general exercise in lower back pain sufferers improves lumbar segmental instability, and just 6 weeks of walking and strength training has been found to lead to improvements in lower back pain. High to very high psychological distress and a high likelihood of psychological disorders, including depression and anxiety, are also common amongst lower back pain sufferers. Negative back pain beliefs can have a detrimental effect on lower back pain sufferers' quality of life and are associated with greater levels of disability. It is widely accepted that exercise can improve mental health and is therefore an important part of lower back pain management. The project in the rural physiotherapy practice incorporated a physiotherapist that was certified in DMA Clinical Pilates levels 1 to 4. The equipment used was a DMA full-size trapeze table and 2 DMA clinical reformers. Population selection was based on the prevalence of the condition seen and the long-term detrimental effect on the quality of life observed. The project was conducted through 40 hours of observation, including initial consultation, clinical treatment, assessment, and delivery of exercise. Information on the lower back pain population was collected through discussion with the physiotherapist. This included the criteria used to select patients for exercise, observation of the physiotherapist-patient discussions, and review of case notes with permission from the physiotherapist. Review of lower back pain and best practice in relation to lower back pain was conducted using relevant peer-reviewed literature. Patient details and informed consent were collected by practice staff prior to treatment. Health and risk assessments and physiological assessments were conducted through clinical treatment of the patients by the physiotherapist and involved verbal communication with the patient regarding the level of pain, activities exacerbating pain, manual treatment, and postural assessment. Patients who qualified to participate in exercise treatment were not required to fill out any health screening or risk assessment forms. However, following clinical assessment, the physiotherapist completed a treatment sheet detailing primary health concern, previous medical history, contraindications and precautions, treatment goals, frequency of treatment, and time until next assessment. This was updated every 3 months or as necessary. Patients began on a basic exercise program delivered by the physiotherapist of up to 8 exercises, with patients encouraged to perform up to 20 repetitions per exercise at each session. Patients prone to acute episodes of of lower back pain started on only 4 exercises. Exercises to improve core strength, posture and movement patterns were selected from the DMA Clinical Pilates database. Patients were constantly supervised with regular verbal communication regarding technique, perceived level of difficulty and pain levels. Participants attended the facility 1 to 2 times per week at a pre-booked time. At-home programs were not given and no behavioural strategies were used. However, patients were encouraged to make further bookings prior to leaving to encourage adherence. The primary outcome measures used to monitor patient progress was the Quebec Back Pain Disability Scale. This was administered prior to exercise commencement and every 3 months following. Verbal feedback was also collected at each visit prior to exercise commencement. Special considerations were given to patients with comorbidities such as Parkinson's disease, diabetes, and psychological disorders such as anxiety. The aims of the program are in line with the ACSM's guidelines and the Exercise is Medicine fact sheet for managing an episode of lower back pain, which recommend physical activity both in the acute and management stages of lower back pain. However, the ACSM guidelines also include recommendations for pre-exercise screening, in particular cardiovascular disease, which was not included. The administration of a screening tool such as the PARQ to all patients may be necessary for adequate risk assessment prior to exercise participation. No allowances were made for weight loss, and with a BMI greater than 25 kilograms per metre squared being found to cause disc degeneration from a combination of mechanical loading and systemic contributors such as inflammation, this is concerning. The contribution of bone mineral density to lower back pain should also be considered in relation to the clinical Pilates exercises observed. Pilates is traditionally low resistance and often non-weight bearing. With more than half of the observed population being postmenopausal women, bone mineral density as a contributor to lower back pain needs to be considered. It is well established that exercise and physical activity can improve or eliminate depression, with depression being commonly associated with disability and chronic lower back pain and can potentially contribute to the progression of lower back pain from acute to chronic. A referral to a dietitian or an accredited exercise physiologist to include cardiovascular exercise for weight loss may be required. And while exercise participation is an important factor in lower back pain, care needs to be taken as it can actually increase the mechanical load on the spine. To improve bone mineral density in the population, the Pilates exercises could be manipulated to incorporate a greater resistance, provided no excess mechanical loading or shear forces of the spine are experienced. Where possible, participation in group exercise is recommended for psychosocial benefits. In conclusion, the observed program met the recommendations for the acute phase of lower back pain. Interventions including cardiovascular exercise for weight loss, resistance training for bone mineral density may be necessary, and allowances for the psychological well-being of patients should be made. Referrals to AEPs or GPs may be necessary. Pre-exercise screening of patients should also include a cardiovascular disease risk as recommended by the ACSM. Practical implications are that clinical Pilates is effective for lower back pain rehabilitation if administered by a physiotherapist trained in this method. Further exercise progressions to improve bone mineral densities could easily be made by the physiotherapist using the Pilates equipment. Cardiovascular exercise to reduce or maintain BMI at a healthy level under the supervision of an AEP can reduce degenerative changes associated with lower back pain, and participating in group exercise can provide psychosocial benefits and improve lower back pain outcomes and quality of life. Thank you for listening.